Okay, thank you very much, everybody, that you are here on the time hearing this webinar for Eureka seminars and new facial seminars. Thank you very much. So the theme today is Bruxism, an update in assessment and treatment for physical therapists from the view from a physical therapist. So first about me as a person, I'm coming from Holland. I have a practice in Holland, a clinic together with my wife, Danielle, and there we treat special patients with orofacial pain. Further, I teach a lot over the world. I give manual therapy courses, international, especially in Europe, but also in America, Canada, about the CRAFTA courses and the manual therapy course in INTA. And further, I'm working on the University of Applied Science in Osnabrück, where we do research, especially on physical therapy, also on orofacial pain, pediatrics, virtual rehabilitation, etc. What you see on the right side. And I'm also teaching on the master's and the bachelor programs. And we have a bachelor master program, musculoskeletal therapy and pain, where I'm the course leader of. So at this moment, I'm in Vienna, and I'm very happy that my internet is very good. So this is the first time we give our courses again in Hamburg, and it's about a month ago for the first time. So we have protectors with mouth mask, and we did some manual techniques, special in the orofacial region, first on balloons. And the picture you see here on the left above was 2 weeks ago. Yeah, so also the social distances was a little bit less. Yeah, and we did our things what we have to do, of course, with some guidance. And I'm very happy that also America starting this month or next month in July, again, new facials and new seminars is also starting again with dry needling courses and the other courses. So yeah, let's be positive and that everything becomes again normal in the future. So I'm Vienna, and you see here the Stephansdom. Yeah, that's a very old church. It's not far from me where I live now. So we have here in the middle of the center, we see here the Stephansdom, but it is not far away from Sigmund Freud's house where he studied and where he did his doctorate in psychopathology. So, and I'm not far from this. I'm here. Happy Harry is here on the Donau, not so far from Stephansdom, who was built a long time ago, but also by the house of Sigmund Freud. And that brings us a little bit to what we bring today, where Sigmund Freud already more than 100 years ago talked about hysteric paradoxism. And he saw this hysterica, that first the doctors thought that it was something with the uterus by a woman, yeah, where you had a pathology of the uterus. But Freud thought, no, this is an abnormal motor response with extreme cramps, what is related with emotional conflicts, and had no structural pathology. So, of course, the hysteric paradoxism was very, very extreme, what you see here on this woman. And yeah, let's say 100 years later, we see still this kind of extreme cramps in the body. But we also investigate this, and we probably don't know what this is, but we talk maybe about catatonia, yeah, some kinds of catatonia, central neural problem, or dystonia, yeah, or facial dystonia, or you can get an brachial dystonia. Or we know from orofacial problems, you can get an trismus. There's a very hard contraction of the masseter where the cause is not known. Or maybe bruxism fits also in this kind of pathology or symptoms. Or gardening. Gardening is a kind of a protection where you are a little bit have a conscience about the situation. So the question mark is here. Yeah, did Freud also not saw some patient with bruxism or with trismus or gardening, what we see now? So the first time that bruxism is really described, yeah, and it was a little bit controversial from what Freud described. That was from Marie Piekartz. She is a German dentist. Yeah, she said that it is a rhythmic contraction of the muscles, yeah, from the masseter, and is very localized, and where the etiology is not known. So from that time up till 2008, 2009, there was a lot of research. Yeah, some say, okay, this is a pathophysiological problem from the brain. Some neurotransmitters are inhibited or excitated, and that gives the problems. Or a lot of psychologists say, no, this has to do with stress and the context, because in some contexts we see more increased cramps in the face or increased cramps in the masticatory system than in other situations. Or it can to do with peripheral inputs. The dentists say, no, maybe this has to do with a patho-occlusion. Yeah? The occlusion is not perfect, therefore it can exist. Or you can get ischemia in your masticatory system, in the muscles, and therefore you get bruxism. So then a lot of therapies are coming out, medication, like psychological interventions, biofeedback, but also occlusal interference, like, for instance, a splint, or maybe also treatment of the masticatory system. So a lot of outcome studies are done at that time and over this 80 years. So there are moderate to minimal clear outcomes. Which therapy is the best way? So what we want to do is to be given a small overview of what an update on bruxism at this moment. Then we go to the proposal of the assessment tools. We talk what we can do in physical therapy in generally, yeah, and propose treatments. So let's start with a brief update in bruxism. And we see here some studies done. The first is the prevalence on bruxism. That is, what we've done is here a study from Lobitzer et al. And Westerlaar. They look to the population, a distant population in what is done in Holland. And that is the same reflection what we see in Europe and probably also in the US or in other countries, is that 5% of the population had a kind of bruxism. And the most what is coming is the sleep bruxism. I won't tell you later about this. And the dominant age is between 18 and 30 years. Yeah, less than when you are 65 years and older. So it comes, the incidence is most between 18 and 30 years. Woman has more bruxism, and special woman has more the awake bruxism than the sleep bruxism. And we see also, and that's very new, that the social economic status, so the way you live, the way how you structure your life, the way what you are doing, yeah, has an influence on the bruxism state. And we have also to mention that a lot of people have also no complaints. So what Manfredini here described in another study, and the same was also done in this study from Westerlaar, that 40% of their patients or persons has no complaints. So you can have bruxism, but no complaints. So then there was a consensus, an international consensus by dentist specialists who are guided by two persons. That was Professor Frank Lobeso. He is a dentist professor from Amsterdam, from the ACTA, and Professor Daniel Manfredina, yeah, from the north of Italy, who also have a lot of experience also with research in bruxism, and they make a group of people, of specialized dentists, who want to reclassify the bruxism. And it was first a group in 2013 and then in 2020. So this is described in Journal of Rehabilitation, several articles, and so they give another definition of the bruxism in 2013. So they work with it, And in 2018, they came back again. And then they refined the definitions, and then they made a proposed assessment tool for bruxism. What is also very interesting for all clinicians, for psychologists, for speech therapists, for physical therapists, and for dentists. So that is what I want to discuss with you together in this hour. So they reconsidered the definition of bruxism and assessment tool. But also another development was in Germany. Yeah, the Germany group, the dentist has also, and that is the DGFDT, the Deutsche Gesellschaft für Funktionsdiagnostik. They are very interested in neuromusculoskeletal problems in the masticatory system. They parallel, together with this group, they developed a guideline, yeah, and they did a very good literature review about outcome from all therapies. For instance, from splints, from occlusion therapy, from protesology, from physical therapy. And that they make the summarize of it in this journal of Cranial Function. And it is in German and in English, so I can send you if you are interested in it, but you can also download this for free on this website, where they give an exactly very good overview about what bruxism is and what the outcome is in different studies. So some thoughts about what patient and dentist and physical therapy thinks. And I want to explain if it is wrong or right. Bruxism is a disease of the masticatory system. Is it a disease? Some I know from physical therapists, from colleagues, they talk, yeah, bruxism is a disease. Another thing is bruxism and bracing. Bracing is pressing of the teeth on each other, are two different phenomena. Yeah, I know that we in the Crafter education, for 3 years ago, we make a very big distinction between bruxism and bracing. Neck pain in bruxism patients is related to cervical impairments. Yeah, so bruxism has pain and myofacial dysfunction in the orofacial region, but it can also give cervical impairments with pain. Or bruxism is a myogenic TMJ. So is bruxism a TMJ? That's the question. And bruxism during the night may be reduced by a good dental splint and has a good outcome for occlusion treatment, like dental splint. So these are some thoughts we want to discuss. One thing is sure, bruxism is a kind of a parafunctional activity. What is a parafunctional activity? That is an abnormal mouth habit. And we all have this. And some people bite on that tongue on the girl on the left side, you see, or you see it by children who biting or moving their lips, or nail biting. Yeah, you can see that also on patients who come in and say, do you nail biting? Yes, no, I don't do it. And then you look to the nails and they are very cut off. Chewing gum, eating and biting, or biting a pen. Yeah, so there are a lot of kind of orofacial activities we probably need to get more sensory information, because the orofacial region is very broad, have a big broad podium on the somatosensory cortex, so we need this input. So when we look to parafunctional activities who directly related are with bruxism, we have 4 kinds of activities or habits: clenching, grinding, thrusting, and bracing. I want to explain this. So clenching is really the condition where I put the teeth on each other and when there is an increase of masticatory activity. What you see here by this woman, she's probably a little bit afraid or angry on somebody, and she holds the teeth on each other. So there's a really high intensity of axial pressure on the teeth with an increase on activity of the muscles. Then the grinding is really the movement of the teeth on each other. And so you get an increase of masticatory activity, with a dynamic teeth contact. It's like a dynamic saw, on, for instance, metal. What you can do, that you grinding on with a saw on metal. And so this is grinding. So thrusting is our movement, where a quick movement is, yeah, from the mandibular, mostly in one side, yeah, who goes with an increase and decrease of speed. What you see by this woman, yeah, she is pulling probably something on the right side. Yeah, you see that the lips are moving, and there's a little bit activity on the left side in the nasolabial region, but she's doing something with her soft tissue, where she had maybe contact or no contact. And yeah, what she's doing is she's biting on the right side of her soft tissue of the teeth. Yeah, and this is an parafunction, what she do. Yeah, so this is an input, as you get a little bit nociceptive mechanical receptor input, but she like to repeat this. Or bracing. Bracing is a forceful maintaining certain mandibular position where there is no teeth contact. Yeah, in both, also in thrusting and bracing, there's no teeth contact, but an increase of masticatory activity. And you see that here, yeah, you see mostly that there's a symmetrical movement of the lips, but also the masseter is increased in activity. Sometimes you see also that the upper lip is rolled inside to the teeth. Yeah, and you see this also, and that is very new from research now, is that it can have to do with a very sorry, my iPhone. Yeah, occlusal dysesthesia. Yeah, so people don't like to have contact with the teeth. Yeah? They have an unpleasant perception of teeth contact. They don't like it. It is not associated with inflammation like periodontal tissue inflammation or let's say an inflammation of the teeth. Yeah, and there's a continuous impairment. Yeah, but discomfort when there is a teeth contact. So there's also kind of what they call a contact phobia. And we don't ask this mostly to the patients, but there are a lot of patients of this. Yeah, in studies was done, there is what in average 10% of the patients who have also are sensitive in the orofacial region, they have an occlusal dyesthesia. And like you can explain it like when you have a shoe, you buy new shoes, your left shoe fits very well, and the right side has an increase of pressure when you stand on it. And you feel a pulling pain on the lateral side of your feet. And so you can walk on it, but if you walk on it, yeah, it is a discomfort. And that is also if you have the teeth on each other. We have a lot of the teeth on each other because if we swallow, we have the maximal occlusion. So if you swallow and try to swallow, you feel that your teeth comes on each other, then you have an axial compression, minimal axial compression of your teeth. So the same if you walk and you have a small shoe on, you have always this discomfort compression on your shoe, on your feet, yeah, and you don't like it, and maybe you won't want to walk anymore. So we can say as a reflection, central regulation teeth contact, yeah, and teeth contact is clenching and grinding. So two main qualities is that the clenching and the grinding is central regulated, so by our brain, and there's a teeth contact. By the thrusting and bracing, we have pivotal initiated, so there can be an activity of the masticatory system. We can also change this. We are conscious about it, and the teeth are apart from each other. And both give an increase in the masticatory system activity. Yeah, that is clear. And all these four behaviors is now, let's say, defined as bruxism. And so we have awake bruxism, what we have during the day, and on the other hand, we have night bruxism, and that can be an overlap from clenching, grinding during the day, but also from thrusting, bracing, and grinding during the night. And so bruxism is a repetitive masticatory muscle activity characterized by clenching and grinding of the teeth, yeah, and by bracing or twisting of the mandible. And specific definitions are by sleep bruxism and awake bruxism. And so we can also divide it in during the day or during the night. And so sleep bruxism is, you hear it already, that there are the activity and that are mostly rhythmic activity and non-rhythmic activity, what can be measured by EMG or polysomnography. Yeah, you can measure that. Yeah, and then there is also teeth contact. Yeah, sleep bruxism you see are mostly in people who have a superficial sleep. So if you are awake and you have to go out your bed at 7 o'clock, yeah, and you feel you have it in your mind that you have to go out 7 o'clock, then you start already of being awake. Your biological rhythm is that you start awake about 6:30. Then you come in the first towards third phase of sleep, and then you also start with sleep bruxism. So sleep bruxism has to do with the way you sleep. And then the awake bruxism is, yeah, the grinding and embracing where you have teeth contact. Probably we know that some people have this. You go to your work and you have deadlines, and there's a little bit of stress because we have to do it on a guideline way, what we have now with COVID and so on. So it can be that you start to increase with awake bruxism. So bruxism, why is bruxism interesting to look for? Because bruxism gives an increase of pressure on the teeth. The axial pressure becomes 4 to 6 times more. Now, and that can give bad oral health consequences. It can give what you see here. It can give abnormal attrition or abrasion, yeah, wear and tear of the teeth. Yeah, it can give also impression of your teeth where you need again an implantation, or it can also start with orofacial pain or temporal mandibular joint dysfunctions. And so it is necessary to look to bruxism and to reduce it. So on the other side, what is then a risk factor for bruxism? Which people get it more than other people? Now, if you have bad occlusion, for instance, you had a teeth extraction and you want not to have an implantation, the unilateral side is you have 2 molars are not there, so you chew always on the other side, and the other side get no compression anymore, and then suddenly you get a reaction of the masticatory system, cause is unknown, and you get an increase of parafunctional activity. Psychosocial emotional components. Yeah, you have some stress on your work, or your planning is deleted, and you need another plan, or your relationship is gone. Yeah, that can have an influence. Or also now about the last 7-8 years is this nocturnal gastroesophagus reflux, so that you get fluid from your gaster coming up in your throat, in your esophagus, in your palatinatum, that gives an increase of masticatory system. The mechanism is not really clear. Yeah, and of course also myofascial pain, TMJ can give some risk factors for bruxism, and of course don't forget sleep disorders. Very interesting also now that snoring, bruxism, sleeping are very associated with each other. People who have a lot of bruxism are also bad sleepers, but we know also that there are a lot of people who have bruxism are good sleepers. Also people who are snoring, yeah, they sleep very well. Okay, so are the advances of bruxism also interesting? Yes, that is also examined and researched. If you have a kind of a bruxismus, you produce more salivation. Yeah, that's good news, of course, for people who have less salivation. Some pathology is in this. So if you have some compression and you swallow, and you can do it by yourself, you feel that some fluid come free in your mouth. It increased the density, yeah, the actual pressure on the bones becomes more, and that prevents you for osteoporosis. They did it on rats and rabbits. There, if you give an actual compression on the teeth, then also the density of the bones becomes more. You can do it by yourself. If you have pressure on your teeth, you cannot breathe through your mouth. So you stimulate the upper airway, in this case. And so you stimulate the inhalation in your nasal region. And it can also give some concentration activity. Therefore, probably also people do this, yeah, during the day when they are very concentrated. Yeah, you bite on your teeth, so you kind of a bracing, yeah, and then it gives an increase of activity of your cortical, yeah, activity. Your decision becomes quicker. This is also known by during studies, during studies that show, yeah, if you do that in a written and for a long time, it can increase concentration. But not all studies are support this, but some studies are. And therefore, this is also examined and researched in different groups, especially also in the older group, that people have seen that if you increase pressure on the teeth, yeah, you get a higher concentration, or there's an association with if you have bite more or you have more actual compression on your teeth, that the concentration is increased. So long term, no prosthetic teeth, so there has to be the normal natural teeth, given a relative memory problems and can give a cognitive increase of tasks by older people. So when we go to the actual assessment of the tools of assessment we have, so we give now a very quick overview of Bruxism. Sorry that I maybe be a little bit fast, but I hope you understand this. And so the last article of this group from Manfredini and Lobiso and Alberg, etc., they did a proposal of a standardized tool of assessment of Bruxism. They call this the STEP. So this is that is an, let's say, proposal that everybody can use. Yeah, and also for neuromusculoskeletal therapy, very interesting. And we have here a subclassification of two axes, axis A and axis B. Yeah, and the axis B, axis A, sorry, is that what we can do in the practice, the clinical-based assessment, CBAs, and the instrument-based assessments. We also can do in the practice, but probably you have to work in a lab or in an academic hospital to do so. And the axis B is to look into the etiology, risk factors, yeah, and the current conditions who are related with bruxism. Yeah, so here we go. So the non-instrumental and the instrumental axis A assessment is self-report. So I can ask the patient, what do you think? Do you biting? Do you grinding? Oh yeah, my partner says that I'm grinding in the night. Yeah, because he becomes awake every night. How many times? I don't know, maybe 2 times. Or you can ask in the morning, how's in the morning? Oh, I have so a stiff jaw. I cannot open my mouth and my headache is already starting. When I move my jaw, yeah, then the pain becomes less. Yeah? So this is a non-instrumental self-report. I can do inspection, and in this axis A from the step, inspection is also to examine. Yeah, I can do some tests, clinical tests to examine, do I find something what support maybe the bruxism. Yeah? Dentists want to look to the teeth. Yeah, the physical therapy is going to look to the muscles, the joints, the nerves. Yes. And then I can do instrumental part. So I can do an EMG or a sonography. You have to do this in a hospital, special clinics who do this. Yeah, where they look to your sleep behavior together with your masticatory system behavior. Yeah, the EMG is now also you can do it at home, but it is still a lot of coaching in this. So the axis 1A, the clinical-based assessments. Yeah, so you can do a current bruxism report, you can do a history, and you can look to the complaints. So you can take a body chart, you can let's show the patient where the pain is, you can ask to the history of the patient. And the patient can say, yeah, when I get small trauma, and in that time I cannot sleep anymore so good, and I get also grinding in the night. Yeah? So we know, okay, probably trauma had something to do with it. And current bruxism is how it is now. Then I can do the A4, 5, 6. I can do an assessment of my joint, muscles, and nerves. Yeah, I can look. Maybe there is also some disc problems. Yeah? Maybe there's a disc displacement. Maybe this is associated with each other. We don't know. And some people have it, some not. And we do an intraoral tissue examination. How is the gingiva? Yeah, do we see that the teeth are very nice, red around in the gingiva? Yes or no? Are there abrasia? Yeah, are there restorations of the teeth? So, and then we can do the instrument-based assessment. Again, probably if you are an average clinician, you want not to do this. So you can send somebody to the hospital or a specialized clinician who do this. And then we get the etiology, risk factors, yeah, who have to be examined. We can do a psychosocial assessment. We can ask some questions about it. We can need some questionnaires, also some standardized questionnaires. I want to show that later on. I can look to the sleep behavior, the medication, some associated pathology like neurological disorders, dystonia, for instance, cervical dystonia, can also have some bruxism, or for instance, Parkinson, yeah, or visceral. We also talk about the GERD, gastroesophageal reflux disorders, and so on. So, because there is not really a good diagnostic test for bruxism, and Daniel Manfredini, the dentist from Italy, said already, we cannot diagnose bruxism. We have to assess bruxism. Yeah, so there is not really a blood test or an MRT to diagnose it. But if we have seen that there is bruxism, that will not to say that it gives also problems. 40% of the patients have no problems. So what we do, we have a grading system. So in the step, they analyze the grading system. The grading system is that you do a positive self-report. Yeah, so you can do some questionnaires, and that's it. Yeah, some people have this, and I think also as a clinician you see this sometimes. So people have a unilateral bulging masseter, and you do say, okay, how's in the morning? Yeah, stiff. I'm in pain. I cannot open my mouth. I don't sleep very well, and my husband said I'm grinding. Okay. Maybe it can be a sleep bruxism. But I can also do a positive self-report with a positive clinical inspection. I palpate the muscle, I look to the teeth, yeah, and I think, oh yes, there's a higher sensitivity in that area. Or I can do an instrumental assessment together with a self-report assessment and a positive clinical inspection. So I do everything. Then I'm very sure that probably there's a bruxism problem. So this is the grading system. I have to say that if you are a general clinician, you probably do 1 and 2. And so you are in the average of grading system. This idea is very cool because if you think on clinician, you can then communicate with each other. Another thing is also in research, you can say, okay, we did the step of grading system 1 and 2. So it is very illegal to do this, yeah, because in the practice, most people don't really go to a hospital to do a polysomnography. Okay, so we can say we have 3 kinds of bruxisms. in relation with the sensitivity of it. That is bruxism grade 1, risk factor 1. There's no risk, no or protective factor. So there's no really a problem in this. It is a risk factor for something else. Maybe you get bad teeth, therefore you have to do something else. And it can be a protective factor, so it protects something, and therefore it can also increase signs and symptoms, or it increase your hypersensitivity in that area, or it can give more neck pain or headache. So we have to look, is it related with the problems the patient had? Is it only a risk factor, or is it not all a risk factor? So, summarize, you can say, we took here to the risk factors, and we look here to the grading system. So I can do a PSR, so that is the personal report. I can do personal report and clinical inspection, and I can do an instrumental assessment, clinical report, and PSR. So probably in the practice, clinician do more. Number 2, PSR, clinical inspection or clinical examination, and then you can give a classification. This is more graded in 1, 2, or 3. And that is the proposal, what the step is. And I think it is a fantastic, good clinical classification we can use for a clinic, but also for research. So what can we do as physical therapists? But it is not so known what physical therapists can do here.
Wat wil je omrekenen?
So first, you can do an...
Laten we dat nog eens proberen. Wat wil je omrekenen?
My iPhone is still talking.
Alle informatie over...
Sorry about this. Probably you have also this kind of things in your practice. And Siri don't everything saying what you want. Okay, so you can do an appropriate screening questions. You can use it together with your subjective examination, and you can do your test. And of course, you do then your test in the craniocervical mandibular region. So proposal, what we can use is the neck disability index, the jaw function limitation scale, that is from the research criteria of Diagnostic of TMJ. The Conti questionnaire, that is also used, very nice questionnaire you can use to classify TMJ, temporal mandibular dysfunction. And you can do the Bruxism status questionnaire I want to discuss later on. And also I can do to psychosocial factors, the anxiety, disability index, and the physical health index. You can download this on the Diagnostic criteria of TMJ consortium website. You are familiar, of course, with the neck disability index. Is first described in 1991 by Fanon. Very good questionnaire, because he tested dimension pain, disability, and function. It has a good construct validity. It is also related with other questionnaires. So we can say, has somebody a clear dysfunction? We need this also, because a lot of patients with bruxism complaints also about neck pain. The Conti questionnaire is a grading system also here. There are 10 questions about the jaw. And then you can subclassify this in 1, 2, and 3. And the more points you have, the more chance you are clearly and cranial temporal mandibular dysfunction have. And so you can also see, had this patient with TMJ probably also a dysfunction, yes or no, in the TMJ. And you can treat the jaw function limitation index. Questionnaire was used by the informed consent to diagnostic criteria of TMJ. Says a lot about the function. Not so clear related with pain and general health, but more with function. There's also a nice study done by Susan Amio-Livio, who works also now in our university several years ago, that there's a correlation between the jaw function scale and the neck disability index. legs. The more your neck also is increased, have impairments. Also, the jaw is more increased in impairments. So this is by TMJ problems. Watch out. Bruxism is not the same as TMJ. So we can use these questionnaires maybe to rule out that it's not a cervical problem or that it's a temporomandibular problem. So last year we published this article in Journal of Musculoskeletal Science and Pain, and we used this questionnaire. This is the Bruxism questionnaire, and these are 20 questions where the patient can say yes or no. And this questionnaire is not valid at this moment, but it is used as a support to get an impression in the grading system 1 and 2 if there is a bruxism, yes or no. So the more points the patient has, the more also there is an idea that there is a bruxism. Here we see the questions. You can download this in this article, what you see here, in Journal of Musculoskeletal Science and Pain. If you not can download it, then give me a mail. I can send you this. Yeah, it is as an attachment by this article. And we used this also in the practice, and we did also use in a study. And then we can use the General Anxiety Disorder Index. 7 questions, and you get a really good impression, about anxiety generally about the patient, because there's an association as a risk factor, and the general health organization, the patient health organization, PHQ-4. So then we do the inspection, and what you see clearly had somebody, for instance, a bulging masseter. By this woman not, but you see mostly that the lips, the upper lip is a little bit smaller. You see the nasolabial region. And if you look in the teeth also, you see that the teeth are not very healthy anymore. You see some yellow areas, zones, in the pulpa, there where the gingiva makes contact with the pulpa. And you see that there's a detraction of the teeth flesh, the gingiva upwards. And a very nice article from Westerlaar, also a Dutch dentist who works also in the ECTA. He together with his group, he want to classify the teeth problems in the TWES, that is the tooth wear evaluation system. And this is also, I've seen it, it's very good also to use for clinician, for speech therapist, physical therapist, to look to the teeth and then make a classification and an implementation, what it means for the therapy. And so you can also communicate better with dentists. So read these articles. They are now everywhere in the journals for dentistry or orofacial rehabilitation. You can get a very nice overview of how you can do this inspection so that you can communicate and that you can classify teeth wear and tear. So if you look to the inspection and the clinical test, we are in this case by bruxism interested in the craniocervical region, but also in the temporomandibular region. So we do an assessment of these 2 regions, and we look to the temporal and craniocervical region, to look if it is a contributing factor, in this case for awake bruxism. Because that I have to say also, up till now, there's only 1 or 2 studies done where you can see that you have influence on the sleep bruxism. And so in our case, when you think of neuromusculoskeletal therapy, we have to focus on awake bruxism. I personally also saw patients who became better in awake bruxism. They had also less sleep bruxism, but that is not a rule. So we do our test, and we do our test where we are good in. We do the physiological movement, accessory movements. We look into noises. We look into the hypersensitivity of the muscles by pain, pressure pain thresholds, statical tests, and so on. And so we want to look if there is a trigeminal sensitivity in that area, and is there really a TMJ on the background of bruxism? So again, bruxism is not the same as TMJ. And then we look to the cervical spine. Some tests were done here, was also come, you see a lot in research, is the physiological movement by the crom, the high sensitivity of the pain threshold in the neck, the flexion rotation test, the accessory movements in the neck, and the intervertebral movements standing out here on, but the craniocervical flexion test. And this cluster of tests give me a clue if there are clear cervical impairments, but still not related with, for instance, bruxism. So I want to introduce you shortly the study we did, on bruxism by have people with bruxism also cervical impairments. So we had in total 100 females, and from dentists and physical therapists in the north of Germany, and we classified them as axis 1 TMJ, so they had not really chronic pain, and there were 12 included. We did neck disability and the self-report of bruxism status question. And then we invited 2 dentists who look to 97 women, female, and they have to decide. They did an inspection, they did an occlusion test, what they want to do, and they did the bruxism self-report questionnaire, and then they have to divide them in clear bruxism, no clear bruxism, and no bruxism. And then we took the both groups, the clear bruxism group and the no bruxism group. Oh, sorry, this one, the no bruxism group and the clear bruxism. And then we compared this with each other. And we saw that in the group with bruxism, they had a higher increase of the neck disability index. There was a significant change or increase of the points in the NDI. And interesting is that it has to do with more hypersensitivity dimension, like pain intensity, headaches, or sleeping. So it had nothing to do with function. So these 3 were very increased. When we look to the impairments in the jaw, the TMJ, we always saw that there was no significant change in the TMJ difference. There was no difference in these 2 groups, but there was an increased mechanical sensitivity. So the mechanical sensitivity was clearer in the bruxism group. And here on the right side, you see that there was in impairments no significant difference, but the sensitivity of the pain or the sensory responses were increases. So, and this is very interesting because probably there's an impairment, there were no cervical impairments, but there was an increase of sensitivity in the neck. Also, we look to the correlation between the Conti and the NDI, and we see here the line, the correlation line from the patients with non-bruxism and with bruxism, and the line is a little bit steeper, so that means that the correlation was a little bit greater, larger. So what we conclude is that patients with bruxism had relative more TMJ, but it's not correlated. But there is also no associated with cervical impairments. So the TMJ dysfunction and the bruxism has no cervical impairment. So that means that the neck is sensitive, but there's no really cervical dysfunctions and dysfunctions. And that we can, of course, very good explain of the model of trigeminal sensitivity. And so there's nociception, increased nociception orofacial system, probably also with centralization, and that gives an increase of a decrease of the sensitivity, and therefore you get also neck pain. Yeah, so neck pain, yeah, is related with bruxism, but it is not the cause. Yeah, it is called a background of the trigeminal sensitivity. So in this study, we could explain that neck pain in bruxism may be projected pain through a trigeminal sensitivity, and rather not through an iatrogenic or myogenic cervical dysfunction. Yeah, and that is probably also good news for us that we, if somebody has an orofacial pain, and you see bruxism, and with special awake bruxism, there is some TMJ, but you find also a lot of sensitivity in the neck. That probably the neck is not directly related with the neck pain, but it has to do with the orofacial region. So, as a reflection, what we have to know if we did this in examination, so we did the clinical inspection, examination, and the self-report. Is there a clear bruxism? Yeah, is there awake versus sleep bruxism? Some people have both. Yeah. So for us, can we change the awake bruxism so that the sleep bruxism becomes better, or that the sleeping becomes better? Is there a clear TMG correlated with bruxism? So it can be that somebody has an intra-articular problem, but is not correlated with bruxism. So we have not to make the mistake that we say, oh yes, you have of course an increase of tension of the muscles because you have an intra-articular problem. Yeah. So the discussion about the intra-articular problem is a debate about it because probably the intra-articular problem, like a disc displacement, has probably more to do with our muscle control than really with an intra-articular problem. Third, are there clear cervical impairments associated with main symptoms? Yeah, so if you find from the 7-8 neck test only 2 related with the pain and the dysfunction, yeah, you have to ask yourself, is this dysfunction also relevant? And what is the trigeminal sensitivity? Yeah, is there unilateral sensitivity, yes or no? And we know that TMJ gives mostly a unilateral sensitivity. Bruxism has more an bilateral sensitivity. Yeah, is it more in the face, or is it more cervical, or is it both? Yeah, so these are the clinical questions we ask. So if you look to this assessment, axis A and B, yeah, as a neuromusculoskeletal therapist, as a physical therapist or speech therapist, and also dentist, we can have a lot of things also to do what we have. And we can check all these points in our daily practice with, let's say, minimal effort and less with our clinical tests and our self-reports. And another thing is that is not really the theme at this moment, but is the orofacial control. It's all more and more clear that people with bruxism, yeah, or with swallowing problems, or who have power function, have also bad motor control dysfunction. They have less variety, yeah, in the orofacial system. So we have also to do some systematical tongue, lip, masticatory, lower chin exercises or examination to look what is there. And we know also that this area on our homunculus is very, very broad. Yeah, and we see here also in this study from Puttenmester et al. Yeah, they let's show you that if you do 1 hour an examination on the teeth and on the lips, there's an extreme activity of the homunculus and all the associated areas. So we have also to look in our assessments to tongue, swallow, bite exercises. Yeah, because there has to be a lot of variation of these motor control habits who are reduced by bruxism. And again, this is still not really examined. It could be very good to examine this in the future. Yeah, because this variety you see in the practice is reduced. So the first technique we do also on the Crafter courses is the tongue, teeth, breathing, swallow exercises. Yeah, this is a technique. Stefan Krauss also described this, I believe, in his book in 1994. We modified this a little bit, yeah, on the background of of the neurophysiology, where you look to the combination of lip position, tongue position, head position, and the swallow rhythm. Yeah, and you do have to do different times and look how does tongue make a wave movement together with stabilization of the neck. About also the habitual reversal technique. This is a very nice technique you can use because there's a lot of context factors by Awake Bruxism. Yeah, so people also correlated with, for instance, the environment. Yeah, so you are in your work, you have to type, then you get an increase of pressure. You start to trust or your task to brace, and then the pain increase. So this is let's say an operant conditioning therapy, yeah, where you have to do a reversal technique. That means that you push your hand on the chin and you give a small pressure, and then there's a decrease of masticatory activity. And this, in the context, can change the neural matrix, so your neurotext, about motor output, together also with variation, yeah, of orofacial motor control techniques of lips, the tongue, and the lower jaw. Yeah, and then we can do, yeah, as a variation, the habitual or the brace relax technique. The brace relax technique, yeah, we have a lot of variation of it. Yeah, you make a small activity, what you see here on the right side. Yeah, you start to vibrate, the patient has to relax, and then you suddenly feel that there's an increase of tension. So the patient starts to brace again, yeah, or trust again. And then you have to make the patient aware of the situation. Say, do you feel what happens? Oh, yes. And yet you look to the time. That was after 10 seconds. So you start to relax. So you say to the patient also, relax, try to be relaxed. Yeah. Think on nice things. So you can also use some cues here. And then you try to increase it. You can do it in very different variations. You can do it in transfer. You can do it in pay activity. You can do in different neck positions. Okay, so because of the time, I want to discuss shortly the musculoskeletal approaches, what we can do as treatment. And this is an overview, yeah, on the background of what we know from neuromusculoskeletal therapy, but also from pain science, that we have to look first. The patient has a neck problem or an orofacial problem. Yeah, so you look to your contributing factors. Then you do an assessment. In this case, you look to TMD and cervical. Maybe also there are some body disruptions. We did talk about this. We don't know if it is also there by bruxism. And then we have to decide, is this a trigeminal sensitivity or not? Or is it more extra trigeminal? And then we start with our treatment and our treatment goals. So one side we can do hands-on. I can stretch the masseter, the temporalis. For instance, here you can do a very nice manual technique. We do this very nice with movement, because it is very sensitive. If you do only in trigger point, for instance, with local pressure, yeah, and you lost sometimes the patient because they don't like it. And we do very soft techniques with stretching, yeah, parallel on the muscle fibers, and transfer movements, yeah, on the trigger point, and you get the same effect, in my opinion. Or here, the treatment of the medial muscle. Yeah, you bring your finger on the medial side, you shift your mandibula to one side, and you move to lateral torsion. You stretch a little bit the muscle, but you do also a very nice transfer movement, yeah, on the masseter, or the tiger medial muscle in this case. Yeah, the pain goes mostly to the ear. Yeah, and you see also that there's a small, nice redness in the area of the mandibula. Then you know the technique is good. There are some studies also done on this. This very nice study from Simone Gau, Dutch physical therapy, who has his PhD on it by sleep bruxism, and she saw that there was an increase of mouth opening and pain threshold, but it didn't influence sleep bruxism. Yeah, one study I found about dry needling, in this case, was done by Biasco and Bonaro. They found that they could influence by dry needling, yeah, on the muscles what we discussed, masseter, pterygoletus medialis, lateralis, and they could improve a 1 week reduce of sensitivity, jaw opening, and pain relation, and also sleep bruxism was a little bit less. So dry needling is probably a good indication. I used it also by a lot by neofacial pain patients in the face, especially by the pterolateral muscle. I'm very happy that I learned these techniques. But there is still not really a good study done on bruxism and dry needling. Yeah, there is some studies done on, let's say, neofacial pain by TMJ, but the new classification is not done. So I'm very interested how trigger point treatments, special also dry needling, have influence on awake bruxism and sleep bruxism. So I can do self-management exercises, and we can do coaching. The coaching is very important. For instance, when to do with an app. This is an Italian group, also the group of Manfredini made a very nice app you can use. So you have to fill in it for 1 or 2 days what your activities are, when you grind, when you brace, when you grind, how long you do it, when you do it, with which activity, and then by an algorithm, this app makes let's say a program for you that you get a reminder on your smartphone or Apple Watch or something. It comes also on your Apple Watch, yeah, and that you do your exercises. So by some patient, I use this, yeah, together with these exercises: bracing, brace relax technique, habitual reversal, and also the TTBS exercise. And for some people, it works very well. Yeah, you can download it for free. I think only the app for treatment costs about two euros, or let's say $1.50. So this is good to do for the patient also. So, and then last but not least, we have to also look to these things, and we have the possibility that we can do hands-on. We can do examine the patient, we can touch the patient, we can move the patient, but we can also explain what happens. So in this case, we can also do a kind of a Bruxism neuroscience education. Yeah, we can explain what trigeminal sensitivity is, that the context can have influence on the behavior on the orofacial region. So that you need systematical exercises, yeah, to do with or without a Bruxism app. Some people become mad from the app because they have put it very sensitive. So then you can say, okay, only use it for 50% of the time, yeah, and then do your exercises. And I can also, from the update neurobiology, yeah, on the books, what you see on the right side, explain the patient very systematically what Bruxism is. Now we plan now a research in it, and before COVID-19 we want to start. It was already through the ethic commission, and yeah, then come COVID-19 and everything stops. So shit happens sometimes. So important is also collaboration with the dentist, with the psychologist. Some people have deep psychological problems, yeah? And a lot of people are very thankful that you help them and send them also to a psychologist. And sometimes also the dentist can be very interested to help with the splint to protect the teeth, not to influence the bruxism, but there is no evidence on this. Yeah, but to protect the teeth, or maybe look to the implantations. So summarize, we can say what we did now in this hour. We get an overview on the actual knowledge about Bruxism. Of course, I'm not complete. There's more than that. The grading system, what we can use, the grade 1, 2, and 3 in our examination. We can apply the step already in our professions. Yeah, the dentists are using this now. So I think also we have to work parallel with the dentists so that we get also our opinion about it. We can do an actual assessment in physical therapies. We have to know that physical therapists are not dentists. Dentists are not physical therapists. We have other objectives, we have other domains, but a lot of overlap, of course. And we can work on the proposed musculoskeletal management strategies. Yeah, what is still in physical not known, there are not really good outcome studies at this moment in physical therapy. Also the Dutch, the German outcome study, yeah, let's show that physical therapy can have some influence on Bruxism, but the studies have a very low methodology and are standard physical therapy and had nothing to do with individual guidance of the patient. Okay, so yes, I thank you very much for this. As a CRAFTA, we are happy to be also in the US. We give the courses everywhere, but especially also we are very grateful to be in America and also in Canada, of course. We planned a course this end of the year, but Mr. Trump said, no, we want not to have European people this year in America. So we don't know if these courses are continue. Yeah, if yes, then you're very welcome on these courses. If not, we plan already by New Pain or Eureka seminars these courses also next year, of course. Then last but not least, I want to also to introduce your the next webinar about tinnitus. I think also here also from a background of perspective of physical therapies, because we can do our specialized physical therapies in this area. I think it's very exciting about it. Yeah, I'm now in Vienna, and also there we talked about the advanced course on this. And yeah, this is Holland. These are the dikes. Also, I believe also in the south coast of the USA. Yeah, if we have not them, yeah, 2/3 of Holland was underwater. So we thanks also the dikes for it. So thank you for your attention. And yeah, I'm very happy to answer some questions if you want.
There's a question from Vladimir from Latvia, who says,
Yeah.
Dr. Piekartz, Professor Piekartz, what kind of intraoral techniques do you prefer for the treatment of bruxism in combination with deep dry needling?
That's a very good question. So my favorite is to do transfer movement to laterally of the head of the mandibula to get a stretch on the pterolateral muscle. And so you go intraoral, you rotate the head a little bit to the left, about 30 degrees, and then you grasp on the medial side of the teeth, go upwards, and then you contact with the index finger on the lateral side, and then you do transfer movements. What I do, my experience is that I first look to this movement, because if this movement, this transfer movement, is very stiff in compare with the long-term movement and the transfer to medial, and my hypothesis is myogenic, and the statistical test to anterior, yeah, is painful, or you see a less motor control. Probably it has to do with the pterolateral muscle. So then I do the pterolateral muscle, because this is also for me then also for reassessment. I get the lobe, I put it from laterally, do it anterior from the head of the mandibula, do the dry needling, and do then reassessment again from the transfer to lateral. If you find that the transfer to lateral is better, I directly do this mobilization. Yeah, and my experience in this, yeah, is that this combination works very good. Not only by bruxism patients, yeah, when they have myogenic problems, but also by patients with disc displacement, yeah, or ear pain, specific otalgia, where the ear pain is nothing to do with the middle ear. Yeah, thank you, Valerie, for this question. Yeah, so try to do this. This is very interesting to combine these two things. But you have to do an assessment before, then you do dry needling, and you do again this assessment. Yeah, we do now maybe shortly. We do at this moment also a research on this accessory movements. Yeah, to get these patterns clear by accessory movements in the jaw. Okay, thank you for the question.
And for those of you who don't know how to ask questions, in your control box is a place for questions. So you can just type it in, I will present it, and Dr. Piekartz will hopefully answer them. So the next question comes from Karachi, Pakistan, from Dr. Mohammed Asif, who says, like, what does bruxism pain actually feel like? Do muscle relaxants help, or does dry needling help in bruxism?
Okay, so it feels like a tiredness, and very, especially the sleep bruxism you don't feel, but in the morning when you become awake and you had this really sleep bruxism, you have a really tiredness in your lower face. Yeah, so it is like if you have a long-term contraction in your biceps. Yeah, and then you want to move your arm, you cannot move your arm anymore. Yeah, so that is how it is feeling. And the second question was, yeah, what's what technique, relax technique you can do? Yes,
well,
there are a lot of
do medications work, muscle relaxants.
Okay, yeah, it's a PAM, for instance. Sometimes my experience that they gave this, but the effect, what I know, so I have to check this, yeah, that the medication is moderate or not. Yeah, so that therefore also that is a problem. Only when you give extreme tranquilizers, yeah, what changes the brain a lot. Yeah, yeah, that can change a little bit, but then you have a lot of side effects, of course. Yes.
Yeah, I can add to that if you don't mind that muscle relaxants like cyclobenzaprine, which is the US the most common one, have much more a central effect and not a peripheral effect. So people get very sleepy and dopey from it, but it doesn't really affect anything in the periphery as far as muscles is concerned. Yeah,
special because bruxism has something to do with your, let's say, with the some ganglia from the brain who you cannot influence a lot with tranquilizers. So it has really to do with your sleep disturbances. Yeah, and also some studies that show that if you change the sleep also by medication, I have to look to this. This is an interesting question, of course. Not all bruxism patient becomes better. Yeah, some change, but some also not. So the cause of bruxism is still not clear. Yeah, so we need probably Freud 2.0 or 3.0. Yeah, to look more to the pathophysiology behind it.
So along that, the same question was, does dry needling help in bruxism?
As you saw, there's one study, what I found up to now, maybe Jan, you don't probably more about it, but I found one study who had influence on bruxism. Yeah, part-wise awake bruxism and sleep bruxism. But all the studies up to now are done with the old definitions. So we need, yeah, also in research now, to classify our volunteers in a new classification, and then do research. So probably also, yeah, we can find then more, let's say, people who are classified as an awake bruxism who say, okay, dry needling is very good for this group, but sleeping bruxism is not. Or in this study, it has influence on sleep bruxism a little bit, but also on the pain during the day. Yeah, but so I can say, yeah, you have to try it. Cool. Look, if a patient has bruxism and in coincidence, the patient had also a TM day, you treat the TMDA, the myofascial TMDA. It can be influenced by bruxism, but we don't be sure. Yeah, that is only what we can say.
Here's a question from Divya, if I hope I pronounced that properly. Do you notice imbalances in the tongue muscles in terms of flexibility in your assessment for bruxism?
Yes, we use it a lot. Yeah, so we look to different tongue tests. Yeah, the strength, the position, the coordination, the endurance, together with orofacial motor control tests. And we know also from other studies, yeah, from low back and cervical, when you offer a variety in movement, also other motor control can change. Yeah, so if you do by low back pain, do a lot of stabilization exercise, you do some recruitment exercises with speeds, with variations, then also the motor control and the normal function from other function becomes better because a lot of motor functions are clustered together. And so in this case, when we find something in the orofacial reading where, for instance, the tongue endurance is bad, or there's a small deviation of the tongue and the force is one side bad. So we try to function to increase this function. Yeah, and then it can have also influence on the behavior of bruxism. Yeah, not always, yeah, but this is what we do, of course, because to increase the, to change also to reorganize the neuromarket of motor control. Again, sleep, probably you have no influence on sleep bruxism, but on the habits during the day, yes.
Okay, next question from Liz. How would you approach the situation where a patient's dentist tells the patient that the only way to stop bruxism is with an appliance?
No, I can tell you I'm not a dentist, but I am supported by the literature. There is no correlation between occlusion and bruxism. Yeah, this what dentists always thought that the occlusion influenced the bruxism, so they try to make splints, yeah, to get another position of the teeth and the mandibula to reduce bruxism. Now, in outcome studies, yeah, it is shown. Manfredini showed this. Lobiso showed this. Professor Turk from Basel showed this in very good reviews. There's no really outcome, yeah, in splint therapy. Does want to say that did not by some people it helps, yeah, but it's the same with physical therapy. Yeah, some people react very good on myofascial treatment by bruxism, but not all patients. So the only thing what we know from literature is that a splint protects the teeth. Yeah, in every country, dentists make very nice and the Michigan splint. Yeah, that is a protection for the teeth. Yeah, and yeah, it helps you to protect the teeth during grinding on bracing during the night. Yes.
Very good. A question from Sarah. Do you believe sleep bruxism is frequently related to an impaired airway?
And the last study I read, but it's several weeks ago, and it's also again another area, sleep apnea and bruxism. What I know is that from the research that people who have sleep apnea have also more bruxism, but it is not correlated with each other. Yeah, so again, you have also to look to the airway during the night. Yes, yes, and some also in America, a lot of dentists are specialized in making splints for better breathing, yeah, for snoring. When patient has also bruxism, you can try this. Yeah, yeah, okay.
Okay, another question from Dr. Mohammed. What vitamin deficiencies may cause teeth grinding? And can melatonin and magnesium help bruxism?
I have no idea. Do you have an idea, Jan? I have
No,
no
I
idea.
really
So
don't.
this is a good question. Yeah. So this is not my domain, but if there are some studies on it, I know that that there is an association with food. Yeah. So if you have viability in food, then your teeth and your gingiva are optimal, but it is not very correlated with each other. Yes, there's more combination. We know that smoking had influence on the condition of the teeth, but is not correlated with bruxism. Alcohol can have bad influence on the teeth, but there you see also cramps in the jaw, but has not to be bruxism. But it's a good question, I think. Yes?
Here's a question from Miguel from Barcelona. Could
Okay,
oral
Miguel.
appliances be a source of parafunction?
I understand not the first word.
Oral appliances like an intraoral splint, can that be a source of parafunction?
Yes, it can be, absolutely. So therefore also you have to ask, did you get a splint of the dentist? Yes, I get it. How is it before and after the splint? Some people don't know it. Are you more awake? Yeah, in the morning. Yes, or are you have more bites during the day? Yeah, then you make them conscious of it, and then you see it probably also more. Yeah, very interesting is also if you put a splint in, mostly when the patient, in my opinion, during the therapy, can you try to put the splint in? You hold it for one minute, and do you feel your splint still? Yeah, normally you have not to feel your splint anymore, like the shoe you put on. And when they say, yeah, on an analogical scale from 0 to 10, I still feel it 4 or 5. Yeah, then probably, yeah, it may be correlated with also parafunction if the patient had parafunction. So, Michelle, that's a very good question. I think we have to be aware for it because when a patient gets a splint, the dentist, the next appointment by the dentist is 2 or 3 months later. And then in that time, we see the patient for several times. So we can guide also if is the splint a good splint for the problems the patient had, yes or no. Yes, so thank you for the question. I think this is also one of the duties to do.
There's another question about the splint from Lisa. Lisa says, like, is there still a thought that splints may change the length-tension relationship of the masseter, thereby reducing dysfunction and tooth damage? And would that carry over to the daytime? She adds to that she had this experience several years ago, and that's what she was taught, but she's not sure what the literature says.
Okay, again, the first question or the first sentence.
The splints, an intraoral splint, does it change the length-tension relationship of the masseter, and by doing that, reduce dysfunction and also tooth damage?
Okay. I don't know. Yeah, that we have to. I know that the German group did some studies on it because I know that from orthodontics by children when they do a bionator, that is also a splint to make more protrusion. You see changes also of the length of the masseter. But I can imagine one group, the group from Schindler, aus Karlsruhe. Yeah, they publish also a lot. And they saw that there is not really a change of the muscles because the muscles are, and they see that as an isolated system. And that is not really direct related, can change by splints. So that's only the answer I can give. Yeah. Yeah. So by children, yes, they have show when child have an overbite, and you gave a splint for the child to get less overbite. Yeah, this has something to do with the stretching of the muscles, and also with the kind of breathing through the nose. And therefore, you get a kind of relaxation and a stretch, of the muscles. And then we have to define what is a stretch on the muscle, of course. Because is that a relaxation that the length become longer, or is it also that the sacrum is changing? So what we know is that when you get a relaxation in the masseter system, and it can be by very simple exercises. When you press a little bit the tongue on the palate, and you breathe through your nose, then you see already a relaxation, of the masticatory system, because this is the normal function. And then you see also more mobility or elasticity, of the movement. So this is really, in my opinion, a central neural regulation mechanism, what happens over here.
Okay, question from Shannon. Do you have any experience or are there any correlations between bruxism and stimulant medications?
Which stimulant medication?
It doesn't say that.
Okay.
But Shannon, you can type it in again if you want to answer the question.
Yeah, we know that caffeine can increase tension. Extreme a lot of caffeine, you can get an increase of tension. But I'm not so familiar with this. So some of course we know that some medication can from the neurological part of view can also give cramps or the trismus. Or I know, but I'm not sure now of which medication. So also radiotherapy with some medication, to damp down the metastasis can increase the cramps or the trismus in the orofacial region.
The last question is from Denise, unless Shannon asks what kind of medications she wants to talk about. Denise has a question. Do you have any experience with patients using biofeedback headbands to reduce bruxism?
Yes, there are, and you can divide them in the unconscious biofeedback and the conscious biofeedback. So the conscious biofeedback you use during the day, so that you get a signal, you try to put an EMG, local EMG on it, and you get an increase of tone, and then you can relax again. It's the same like how, for instance, the app working. But you have also some experience I've done now with, they call this the Brux stop. So you get a headgear on it during the night. They measure your EMG activity and then give small currents in the masseter, so you relax. So before the bruxism is coming, the sleep bruxism, it relaxes. Now, there are also studies done at this moment on this Brux stop, and the outcome is relatively low. So there's not really a significant change in sleeping bruxism when you used it. It is a very good idea that you measure the EMG activity. You come in the first or second phase of your sleep. Then you trigger, for instance, your masseter. You get a relaxation, and you have less teeth contact. But also the effect seems to be also in sleeping labs relatively low. So I think we can use the neurofeedback during the day. You can, we see here this techniques we did, the habitual reversal technique, the tongue breathing, swallowing, the break relaxation, more of that. You can do this during the day, but you need a reminder. The reminder can be, for instance, the app. Or you can use, for instance, other things like a biofeedback. It's also possible.
Okay, that was the last question. We have one more comment. This was a very informative webinar. Thank you, Dr. Harry, Dr. Jan Dommerholt, and thank you, MyoPain Seminar. So with those words, I would like to thank you, Harry, for presenting this.
Thank you very much.
I know it's late for you in Indiana, so
yes. Have a nice day.
It's not as late for some of the participants. For some of the participants, it's now 3:30 in the morning, so they beat you to. But thank you very
Have a
much.
good
Thank
night.
everyone, and we hope to see you all again next week with the lecture about tinnitus, where Michiel Trouw, also one of the senior CRAFTA instructors. So we'll see you again next week. And thank you very much, Harry. So this is the end of this webinar. Thank you all very
Thank you for
much.
your coordination.
Good night.
Okay. Bye-bye.